Now let's welcome our second speaker, Dr. C.
Good afternoon, and I'd like to thank Sabrina for setting the scene straight. And may I just have a show of hands, how many people here are cancer survivors? So that's really very encouraging to see that we have quite a number of individuals here who have gone through possibly breast surgery. So maybe perhaps what Sabrina has mentioned, you may have think, wow, this is new. Last time I got this one, I will sure do one. So she had a tremendous number of slides, but I think she put all the most important things ahead. I have been left with 12 minutes to go through my spiel, and trust me, I only have 18 slides, 1-8. So we're going to get to the Q&A, which I think is very important. Now, it would be a shame if we expected you to be able to learn everything about breast cancer, a tailored treatment within this 1 hour, or even less than that, 15 minutes. A simple consultation in our clinic can go on for 2 hours, knowing about everything. But suffice to say that I often call breast cancer diagnosis a life-saving diagnosis. We always think that breast cancer is a death sentence, but actually it shows us what we have been doing, which may be improved, and what we should be doing for the rest of our lives. And the most important thing to realize from that sentence is that we have the rest of our lives. We talk about longevity. We talk about the life expectancy of a lady in Singapore being at 85. My mom had breast cancer when she was 83, and she's 86 this year. And she is in any way going to die from breast cancer. My dad had a heart attack at 88, and he's going on to 90 years old. I'm not quite sure who is the one who's going to kick the other one. But as far as I'm concerned, my dad used to be very worried about my mom, and I think the worry gave him the heart attack. So it is important that we realize our risks so that we don't give each other grief, right, when we do get diagnosed. As Sabrina has put, the 5 things: know your own risk, get scanned, and get screened, because we can't always wait until there are lumps and bumps before we get diagnosed. So she has put everything correctly. I mean, breast cancer is on the rise, but cure rate is also on the rise, and know the symptoms. But by the time there are symptoms, it is usually considered as stage 2, or if not, sometimes already far later the stage. So she's gone through this. Also, some of the risk factors are genetic predisposition. In Singapore, it is not common to have BRCA mutation. In fact, it's less than 2.5%. But there are several other mutations, which, as she has mentioned, is VUS, variant of uncertain significance. It doesn't mean we don't know enough about it. It just means that we haven't tested enough people to know whether these mutations are associated with cancer. We perhaps all have some mutations, but many of these mutations are what we call background noises. Nothing is going to happen to that person if they manage their own personal risks. What's more important is the factors down below. Radiation exposure, which rarely happens. If I had a patient who lived in, say, Japan, or who was exposed to radiation when she was in Russia, when she was a kid, yes, then the risks are far higher. What's more important is smoking, obesity, and physical inactivity. These are more important because fat is actually not a inert organ. Fat is actually a very, very, very active organ, and above 35% of body fat, this organ becomes very pro-inflammatory, and it will cause our body's own immune system to go down and not help in looking for these pre-mutative, pre-cancerous cells and wipe them out. So immune system is very important. So how do we improve access? Number 1, we need to be increasing our own awareness and assessing our care. Clinical evaluation, diagnosis and staging, and access to treatment. I am very sure every single person here has got a basic MediShield life, and I think that's something that our government has given to us. But treatment for breast cancer does not need to be expensive. It can get expensive, but it need not be expensive. Very simple treatments can be given, and the earlier we diagnose, the simpler and therefore the cheaper the treatment will be. We want to achieve high cure rates. We want to achieve 5-year survivals of more than 95%. And money is not the way to do it. Early diagnosis, early access, get rid of the fear, get rid of the myths. That's how we reach that 95% cure rate. So improving diagnosis. So it says, hey, I hear there's this blood test that I can test for 50 cancers. Is that accurate? Well, yes and no, because some breast cancers are very, very low grade and they don't have much mutations. Therefore, we cannot pick up these mutations from blood tests. If the cancer is advanced in stage 4, then yes. So some of these blood tests are there to pick up advanced cancer, pancreatic cancer, stomach cancer, for which there is no screening technique. But for breast cancer, for many of our patients, maybe up to 40% of our patients, present with ductal carcinoma in situ, or what is known as stage 0. Now, stage 0, it doesn't even respond to chemotherapy. So at this stage, the only way we can find it is through a mammogram. There are no lumps and bumps. We'd be lucky if there was, but it's usually through microcalcification in mammograms. And this is also the same reason why ladies who have had breast cancer on the one side require to continue to do it, to look for these microcalcifications for the next 50 years of their life. If we didn't think ladies were going to survive breast cancer, there is no need to do these mammograms after diagnosis. It is because they're going to survive, that's why we continue to do it. And Sabrina has gone through the different types of mutations and the different types of cells, but suffice to say, histology is most important. I can't tell, but just by feeling the lump whether it's going to be cancerous or not. We will always have to put that needle into the lump. It will not cause it to spread. There is always this myth that if you poke it, it will spread, it will explode. But very often, because I or the surgeon need to put a needle in there to make sure it is cancer before I send the patient for a scan. If it's not cancer, I scan for what? So it always feels like it was okay one. I was feeling fine. Then the doctor go and put the needle in there. Now it's spread all over the place. But it has got nothing to do with the doctor doing that. It was already spread. But I needed to make sure that there was cancer before I did the scans. And she has mentioned there are many different subtypes of breast cancer. We will usually put them into 4 types: luminal A, luminal B. Luminal A happens in patients who have a higher age. They are very low grade. They grow and they grow old with a patient. We see 90-year-old patients with luminal A, slow growing breast cancer. Then we see luminal B, which is a little bit faster. These will benefit from both chemotherapy and anti-cancer hormones. And then there are the other 2 swear words, triple negative and HER2 overexpressed breast cancer, which are so quote unquote aggressive. And we are beginning to know more and more and more. Even within HER2 overexpression, triple negative, there are more and more mutations that we find. Are they basal-like? Are they BRCA related? Are they this? Are they that? This is even jargonish for oncologists who are in training. So let alone patients. So it is not necessary to know too much about this unless a patient has got metastatic stage 4 cancer. So how do we improve appropriate treatments? Appropriate treatments means if it's early, we just take it out lah. That's all we need. If it's very, very early, then Sabrina can take it out with a microscope or this scope thing, tiny keyhole surgery only. So again, the take-home message is get it diagnosed early. Don't wait until it spread. Don't wait until it becomes a lump. Just don't wait. Feel something, just go and get it resolved. So improving the appropriate treatment. If I have a small lump, the surgeon will and should not ask me to do a mastectomy unless I have a very high risk and I'm a genetic mutation carrier. And then appropriate treatment would be, has it spread? If it's spread, then can I live for the rest of my life with my breast? Because you're not gonna cure me, right? If I got diagnosed at 45 and it's already spread and I've got 20 years to live with this cancer, then you might as well let me keep my breast lah. So appropriate treatment means if we know that cancer has spread, then we try not to recommend patients to go for quote unquote unnecessary breast surgery. This is again if we think that the breast surgery isn't going to improve the patient's chances of treatment, recovery, and or quality of life. Of course, notwithstanding, when we say a patient has got stage 4 cancer, sometimes there's a solitary metastasis in the bone. or a solitary metastasis in the lung, or a solitary metastasis in the liver, and this happens to be a slow-growing cancer. So sometimes we offer breast surgery and surgery or radiation to the involved site, and the patient still goes on to be cured. So again, the word stage 4 is not a swear word. It just tells us, hang on a minute, we need to think again before we just go in and take out the tumor and then tell, oh, sorry, spread already. So some cancers will benefit from chemotherapy. Some cancers do not benefit from chemotherapy. 25 years ago, it was everybody gets chemo, everybody gets surgery, everybody gets radiation. And then 25 years later, we have patients who come back and tell us, hey, I survived breast cancer. Thank God I got chemotherapy. Actually, now we know some of these cancers would have not benefited from chemotherapy anyway. We just gave them the credit. These are called low-risk cancers, right? We have a gentleman in here who actually brings us the ability to do that. And some of these genetic arrays are Oncotype DX, MemmaPrint, which helps us to determine the pattern of the tumor. Is this a low-risk cancer for which no matter how much chemotherapy we give, ain't going to do anything? Just doesn't do anything. Lose hair and that's it. Maybe give like a 1% advantage. But if you ask anybody, 1% only, but 5% chance of side effect, nobody's going to get the chemotherapy. But if I want that 1%, okay, can still give, it won't harm. But some patients get all the side effects of the chemotherapy and none of the benefit. Some patients get all of the benefit and none of the side effects. Do I really know I'm going to be which one? I can't always. So in the past, everybody gets everything. Then survive, that's great. But now we can tailor it. If it's a high-risk cancer, these patients will benefit from chemotherapy. So their little bit of suffering is very worthwhile. So this helps us to tell whether early-stage patients will benefit from adjuvant chemotherapy or not. Now, some cancers benefit from getting the chemotherapy before the surgery because I can tell that the cancer shrink. After surgery, if Sabrina takes out all the cancer, then they come to see me for chemotherapy. The patient will ask, hey, how you know that the chemotherapy works? No more cancer already. Can't see it shrink anymore. So we must retain the cancer in the body. That sounds terrible. But we retain the cancer in the body and give the chemotherapy. And is it just keep our fingers crossed, hope that it shrinks? No, all cancers will shrink. It's just a question of how much will it shrink. Can we make a surgery less invasive? Can we allow a patient to make a decision to do bilateral mastectomy if they were a genetic mutation carrier and then avoid further treatment 20 years down the road? All these questions need time to resolve. So before we can resolve that, we give the chemotherapy. We control the cancer first, let it shrink, and maybe I can get away with minimally invasive surgery. So this is called neoadjuvant chemotherapy. Some cancers, as we mentioned, these are what we call guidelines already. The clinical question is which of these patients are appropriate. The tumor grade, the higher the grade, the more beneficial. Why? Because the higher the grade, the more chemosensitive they are. Means they shrink faster, and these patients will need chemotherapy anyway after the surgery. So if I'm going to get the chemotherapy before or after the surgery, does it make any difference to me? The higher the grade, the greater the chance chemotherapy given before the surgery is going to improve the chance of cure. Because the cancer is there. I say go from this size to this size. If there's any residual left, I can give a little bit more treatment to improve the chance of cure. If Sabrina takes out the tumor first, I can't know anymore. I can only base it on the previous clinical trials that, hey, this arm works very well. But I don't know whether I will belong to the person that will benefit from it. So having chemotherapy up front is not because the patient has advanced cancer. It just means that I want to know what you give me is going to shrink the cancer, and if so, how much. So that's called neoadjuvant chemotherapy. This is a very busy slide. If you go to ChatGPT, Google, any of the AI, they will generate 3-page discussing this with you. We are trying to find the best patients to give these targeted therapy. So it can go from that to that and that to that. So, just now I was sitting down here with the AML lecture given by Dr. Lee, right? A lot of nice photos before and after, before and after. Before and after is like a hard sell, hey, you see this before, then after that, no more already. But for breast cancer, we do see that before and after. In fact, it's important to see the surgeon before the chemotherapy because sometimes the cancer shrinks so fast, I can't feel it anymore. And by the time we go in and try an ultrasound, it's gone. Then the surgeons don't know where to operate anymore. They need to go in and put a small clip so that they can know where to operate on the ground zero. So this is my last slide. These are patients with very advanced cancer. The lady on the left, she chose to leave it alone because she was very scared. Painful or not? Not painful at all. Why? Because the cancer has already destroyed all the nerves. What's that? No more pain already. What? The one on the right, in fact, it grew really quickly. It grew in the time she was trying to find who was going to be the best surgeon for her. And by the time she turned up at the surgeon's clinic, hey, this one, no lah, cannot lah. So, actually, 20 years ago, a good surgeon would have just gone in and took it out anyway, leaving with positive margins, and then the cancer would come back very quickly after that. So now we know we would never put such a patient through surgery anymore. We just simply give them targeted therapy. The lady on the left didn't even receive chemotherapy. She just received an oral medication and dual targeted therapy, and it just shrank away like this. No pain. The lady on the left received checkpoint inhibitors, immunotherapy for triple-negative breast cancer, and it shrank as she went in for minimally invasive surgery. So that's my last slide. So I just want to basically say that if you have nothing else to take home what Sabrina has said. Get the diagnosis early, and if you have friends around you who have never gotten breast cancer, then enjoy your status as a survivor and say, hey, nowadays surgery can be keyhole only, even for breast, not just gallbladder. Why don't you go and get it diagnosed? Join me at the Cancer Society or come here for the Mema Bus. If we see something, quickly go get it done. It's very, very important. Don't spend unnecessary money on advanced treatment. If can, we save money for a good holiday by getting a mammogram done when we turn 40 years old. And with that, thank you so much for your attention.
Thank you so much, doctors.